the third scientific session, and for this particular session, I would like to invite, rather it's a pleasure to invite ever enthusiastic Dr. Sanjay Shah. He is an endocrinologist and founder member as well as the president of Howrah Town Diabetes Study Society, who is attached to Narayana Super Speciality Hospital. And he is going to present the topic of an interesting case. And to chair this particular session, I would like to invite Dr. Purushottam Chatterjee, who is an endocrinologist. Along with him, we would also like to invite Dr. Buddhadev Mukherjee, who is a very senior general physician of Howrah and patron of Howrah Diabetes Study Society, and Dr. Shotinath Mukherjee, who is a renowned endocrinologist, professor at SSKM Hospital. I would like to invite chairpersons for this particular session, and I would also like to invite our speaker for the interesting case presentation.
Purushottam, chalo. ডাউনলোড তো করলো কি করে নাই ওখানে ডাউনলোড করলো তো ডক্টর সঞ্জয় শাহ
So good morning, Sanjay, if you are ready with your slides. We are running late, so maybe without much further ado, I hand over the podium to you. Thank you.
Thank you to the chairpersons. Thank you to all my colleagues who are here, including delegates and seniors. So I will take the liberty of presenting two cases. Very interesting cases which have been technically life-saving for patients, so it's a fairly serious take-home message. And I will just, as Howrah Town Diabetes Study Society basically tries to involve the younger generation more so that perhaps we need to provide that platform, I would request Surendra to come in and basically present the two cases, and then I will finish by saying what we did for these two patients. So over to you, Surendra. Come.
Thank you, sir, for giving me the opportunity. Good afternoon, everyone. Myself, Dr. Surendra. I am honored to be here with my God, Dr. Sanjay Shah. Today we are going to discuss about the decay and its complications. Decay is a medical emergency first described in 1886 and almost universally fatal before the discovery of insulin. Insulin brought down the mortality from 100% to 20%. Understanding the fluid and electrolyte balance and ICU care brought it even further to 5%. Today it is said that patients die from the underlying illness rather than the ketoacidosis itself. The case number 1, she is a 29-year-old female with a history of diabetes for 2 to 3 years and was on oral hypoglycemic agents. She was admitted at a local nursing home with acute abdomen and found unconscious after 24 hours of treatment with IV fluids, antibiotics and insulins. And she was promptly transferred to the West Bank Hospital. And on presentation, she was drowsy, febrile and hyperventilating and maintaining saturation with 5 liters of oxygen. Her vitals are BP of 140/90 and pulse rate of 150. The abdomen was distended but soft, and there is no neck rigidity and plantars were flexor. And further investigation showed hemoglobin of 12.6 and total count of 42,000 and sodium of 146, potassium 4.4 and renal parameters were unremarkable. LFTs were mildly deranged and MLS was slightly elevated. And blood sugar was 426 and chest X-ray unremarkable and ECG showing sinus tachycardia. And ABG showed severe metabolic acidosis with pH of 6.9 and bicarb of 3.8. And we treated the patient with as diabetes with sepsis. She was
sorry
given.
to interrupt you.
Yes, sir.
Could you go back to the previous slide? And the one before that?
Yes.
Yeah, so stay there. So do you believe this patient had acute pancreatitis?
No, sir.
Okay, so the high amylase level, how do you explain that?
The amylase levels are falsely positive in acidotic states like
Right.
any
So
acidosis states.
did you look at the lipase?
No, sir.
So you sincerely did not think that this could be acute pancreatitis. The reason I'm asking this is you don't have the serum calcium. So could you give us the calcium level also at this point?
So we can check the calcium levels, sir.
So, okay, now we
Yes,
can
sir.
proceed. Thank you.
She was treated in lines of sepsis with IV insulin, IV fluids, potassium, and antibiotics. She was reviewed by surgeon and gynecologist. Blood sugar started to improve. But within a few hours, she was in increasing respiratory distress and was intubated. And next day, she was transferred under Dr. Shah. And over the next 4 days, the acidosis gets corrected with serum bicarbonate of 20 and urine ketone trace. Her blood pressure was 130/80 and pulse rate was 100. Her electrolytes and renal parameters were unremarkable. Her consciousness improved gradually. She was planned extubation and it was successful. But after 6 hours of extubation, she was become drowsy, tachycardic, and had an labored breathing. And repeat ABG showed type 2 respiratory failure, and she was reintubated. Yes, sir. And considering to having overwhelming sepsis,
Sorry to stop you again here. Could you tell us why the bicarb was like that with such a low pH? PCO2, I understand. You said the patient was hyperventilating. That's perfectly understandable. This bicarb of 20, is it consistent with your diagnosis of DKA? Because you have to demonstrate hyperglycemia, ketosis, and acidosis. This patient doesn't have a significant ketosis.
these
Did
are
you check-
the,
Yeah.
these are, on admission, she has a severe metabolic acidosis, sir. After insulin and fluid, we corrected the parameters, but she had a respiratory weakness and got
Yeah.
type 2 respiratory failure later. Sir.
Right. Her urine ketone was trace. So did you have an opportunity to look at the serum ketone also? Do you do it in your hospital? Oh, sorry. You don't do that. Okay, fine. That's okay.
I think the idea was that this patient's DKA had resolved,
Yes, sir.
but something else seems to have happened, which has resulted in type 2 respiratory failure. That's what it was actually, is trying to show actually.
Okay, please proceed.
Considering to having overwhelming sepsis and change of antibiotics to meropenem and linezolid done. And the next day on ventilation, there is no spontaneous breathing. Next, follow-up investigation showed hemoglobin of 8.1 and total count of 16,000. And renal parameters and electrolytes were normal. Sugars were maintained around 150 to 250. And there is a mild derangement of LFTs. Technically, DK has resolved, but she is still in coma. The possible causes of coma here is DKA or hyperosmolar non-ketotic acidosis and hypoglycemia, lactic acidosis, cerebral edema, or other causes like stroke. We did an CT brain, which was normal. What next? Before going to the discussion, we will continue with the second case quickly. She is a 45-year-old female who was started on oral steroids recently for lichen planus.
Sorry. No. This case, please go back. So what did you do with the hemoglobin? Hemoglobin was 8.1. So did you do something about that?
So it is most likely dilutional, but we transfused 1 unit of PRBC.
Dilution with what? Overzealous saline infusion? So, and did the patient go into heart failure?
No.
Anyway, we do not have those data, and I'm still waiting for the calcium and the phosphate, which I think is still up your sleeve and will come later.
Okay.
Okay, please proceed.
Case number 2 is a 45-year-old female who was started on oral steroid for lichen planus recently. He was admitted in a drowsy state, tachypneic, high blood sugars, and with a history of multiple episodes of vomitings, and found to have metabolic acidosis and ketonuria. CBG was around 500 and AB is showing metabolic acidosis with pH of 6.9 and bicarb of 4.1. Her total count was 23,000 and there is a moderate elevation of amylase and lipase. And ECG showed sinus tachycardia and tropi, there is a significant elevation of tropi. And echo showed hypokinetic anterior posterior wall with ejection fraction of 42%. We treated her with IV fluids, IV bicarbonate, potassium correction, and antibiotics, and antiplatelets and statin for ACS. In spite of the decay resolving, the patient was in persistent hypotension, requiring the inotropic support. So putting the patient on subcutaneous insulin was not a great option. Therefore, Dr. Shah was consultant, and what next? I'd like you to invite Dr. Shah sir to take the discussion forward.
No, before Dr. Shah takes over, did you use insulin to treat this patient?
Yes, sir.
It was not on your chart.
So,
If you could show us. Yes. So where is your insulin?
sir. Thank you.
With a blood sugar of 500, this patient did not have insulin.
IV insulin was given. So I think we
Okay, thank
omitted it unconsciously, subconsciously, whatever it is, but I think this patient's decay was being treated with IV insulin. I think so. What we're trying to show chairpersons is that these two cases, there's a difference of about 10 years. The first case was in 2013, which perhaps taught me a lesson. And the second case, as a consequence of learning that lesson, we perhaps managed to act more promptly. So I will share what happened. So when you have something which you do not understand, so a comatose patient whose decay has resolved, you do a CT scan, you think about LP, but you still don't know, no spontaneous respiration. Ki korbo, there's nothing, you're at sea, okay? And you are basically clutching at straws. And Sotinadda asked, so what did you do with the hemoglobin 8.1? Yes, we gave 2 units of blood. But that was not the biggest problem. The problem was, why was she comatose? And she was unconscious and dying, like a sinking ship in the life of Pi at that time. So when you don't have anything to do, you clutch at straws and do whatever else that comes to your mind. So we did a calcium check, a magnesium check, and a phosphate check, okay? And what it showed essentially, that she had significant phosphate deficiency, a phosphate of only 1 milligram compared to 2.5 and 4.5 being normal. Now, this is perhaps phosphate deficiency, but does or can it do what it is doing to her? And that was a learning thing for me. Can all this be due to phosphate deficiency? And lo and behold, if we look at the acute deficiency in phosphate, can produce neuromuscular manifestations like muscle weakness, fatigue, paralysis, respiratory failure, oculomotor palsy, cerebellar tremor, seizures, coma, and death. And she had some of these features while in hospital. And she can also have cardiac dysfunction due to impaired muscle contractility, and hemolysis, platelet dysfunction, spontaneous GI hemorrhage. All these things can happen to your patient with acute phosphate deficiency. So clinical manifestations reflect a generalized defect in cellular energy metabolism, okay, because of ATP depletion, because there's very little phosphate. Phosphate is required to convert ADP to ATP, and phosphate deficiency would result in ATP deficiency. So it's all is basically due to phosphate deficiency. With reduced ATP levels and hemoglobin that is reluctant to donate oxygen, the above mentioned problems seem to have occurred in the patient. Patient was comatose with no spontaneous respiration and being ventilated in spite of we successfully treating her DKA. So if you look at phosphate metabolism at large, nearly 85% of the 600 grams of phosphorus is in the bone. And phosphorus is a major intracellular constituent. Phosphate is widely available in food, so it is ubiquitous in nature, but in DKA, they unfortunately do get severe phosphate deficiency. It is recognized and is written in the books as well. And you have to remember that glucose also needs to be phosphorylated before being utilized as an energy source. So extremely important, particularly when you have severe acute phosphate deficiency. The three mechanisms of low phosphate can be decreased GI absorption, patients having decreased dietary intake, that is one, and low vitamin D. You can have increased renal loss from osmotic diuresis that happens in DKA. So you have high parathyroid, low vitamin D, renal tubular abnormalities that you can, and then you have redistribution into cells, okay? And that may, and the insulin per se can also perhaps result in phosphate deficiency. So phosphate deficiency in DKA, when we treat someone with hyperglycemia, the insulin enables the movement of glucose, potassium, and phosphate from the blood into the intracellular space. These patients are intracellularly glucose deficient until you start giving them insulin, okay? And therefore, the sudden appearance of glucose in the cells will drive glycolysis, consuming more phosphate. Someone with hyperglycemia is already phosphate deficient because of osmotic diuresis. So correction of the acidosis also drives the phosphate into cells. So these issues basically result in DKA patients having more phosphate deficiency. So what we had was she had phosphate deficiency. Now, the thing was, we came to a diagnosis, but what can we do for such a patient? This was 10 years back. At that time, Shotinadda, there was no oral phosphate available in India, neither was there intravenous phosphate available in India. So what did I do? Okay, so replacing phosphate was important. Oral phosphate not available in India, IV phosphate not available in India. So we also must check calcium. What did I do? The only phosphate that I knew 10 years ago was a phosphate enema. Okay, so how do I put this phosphate enema to the patient? The only way I managed at that time was I diluted the phosphate enema by 3 times the volume of water. And since it doesn't need to be sterile because you can use it orally, I gave this patient this osmotic laxative orally through the Ryle's tube. Okay, through the Ryle's tube we managed to do that. Okay, and we managed to give her 3 grams of phosphate. And honestly speaking, it was truly magical at that time. Phosphate enema diluted and given through Ryle's tube, and the phosphate increased from 1 to 5 to 2.9 to 2.6, and as a consequence, spontaneous respiration returned. So the clinical outcome at that time was she survived, she went home on diabetes, diet, and insulin. And to top it all, you know, even the 4th class staff in the hospital had told me, sir, apni kintu enema kintu tube dichchen, sir, jodi patient party jene nae, tale kintu somosya hobe. So this is the kind of challenges we face as doctors. But the science of understanding is extremely important. And this is perhaps, I think, it actually saved the patients' lives. And I learned a lot, and so many of my colleagues perhaps have learned as well as a consequence. So when the second patient came, and this was a patient who had corrected DKA, but persistent hypotension, blood pressures of 80 or 90 systolic with noradrenaline infusion. And my colleague, Dr. Gupta, is not here today, but he asked me to see this patient. He's saying, I can't give this patient subcutaneous insulin, blood pressure is low, I am to give noradrenaline. The DKA chikitsa korbo ki kore? So I checked her serum phosphate. Her phosphate was low, 0.9. This time around, IV phosphate is available. We gave her IV phosphate. Her blood pressure came up to 130 by 90 without inotropes. So she can now perhaps be given subcut insulin, and we managed to do so. Her 2D echo, which was showing global hypokinesia, with a ejection fraction of 40%, became 58% after giving IV phosphate. And as a consequence, we managed to give her the basal bolus insulin and send her home. So essentially, checking phosphate and treating the same actually can be life-saving. At least these 2 cases highlights that, and I wanted to share that with all of you. including my DNB student, Surendra. I think it should be routine, Swatinatha. That's what I feel very strongly now about phosphate checking and decay.
Yeah, right. And thank you, Sanjay, for the wonderful presentations. Couple of comments. When you have anemia, acidosis, and a low phosphate, which means low intracellular 2,3-DPG, these are the three driving forces that push your oxyhemoglobin dissociation curve to the right. So this patient had the case 1, severe anemia, then acidosis, then low phosphate. So poor oxygen delivery to the tissue, including the brain, which might have contributed to our coma. So naturally, we expected that the patient would be infused with PET cell. Then you took care of the phosphate. The point is, routine phosphate estimation is not recommended in DKA.
I know.
If the patient fails to improve after correction of acidosis, hyperglycemia, and potassium, only then one needs to take a look at phosphate. And we do get low phosphates. And say 10, 20 years ago, as you say, rightly said, oral phosphate was not available in the country. We started using the same phosphate enema orally without telling the patient that this is enema. Simple. Patient did not know what he or she was getting. But it's highly effective, as you rightly pointed out. So it takes care of the situation. And in those days, I had a colleague, he's still there at Sick Children's Hospital, in London. So whenever he used to come to Kolkata, he used to bring loads of oral phosphate for me.
Sodium phosphate tablets, yeah.
Yeah, so ours being a free hospital, so he used to bring in those phosphates for us. So thank you. Thanks for the wonderful presentation.
Yeah, I just thought that perhaps I will share the case. Arjun.
Yes. I have, sir, two comments. So regarding the elevation of the amylase in the first case, it could be because of the salivary amylase elevation, that is a non-specific, that can happen in decay. In the second case as well, but in the second case, there was clear-cut elevation.
In the first case, I think our lipase should have been checked. Yes. Because acute pancreatitis as a precipitating factor for DKA can cause lowering of ionized calcium as well as phosphate, yes, due to soap formation. So
in the second case, the lipase was clearly elevated. That could be because of the pancreatitis itself, and the cause could be the patient was already on exogenous steroid. So that can be the cause of pancreatitis. What about the imaging of the pancreas? I want to know that.
Yes, Sanjay.
So the second case.
As far as I
second
know,
comment,
remember
sir, let
the
me finish,
ultrasound
sir.
did not show anything significant.
The second comment, let me finish. I have talk in the next hall, just after this.
He has a talk at the next hall, so
yes,
okay.
He has to finish.
Hypophosphatemia in decay is very, very rarely, as sir has pointed out, that is usually a complication of management of decay. That usually happens after management of decay, hypophosphatemia.
Yeah, because insulin pushes potassium back into the cells. Sanjay?
Absolutely right. That's the reason why both these patients, after resolving their diabetic ketoacidosis, were running into major problems, both of them. And that is the reason why I know the recommendations are not there. I am not writing guidelines, but I think somewhere along the way, something like this which can save lives, there should be because it's easy to treat and easy to basically test also. So, but I rest my case. I'm not somebody who perhaps writes guidelines. That's how it is.
No, but very important learning points that you mentioned. Thank you once again.
Thank you.
Close the session here.
Thank you, Speaker, sir, and thank you, Chairpersons. I would like to request Chairperson, sir, to kindly felicitate our speakers today. Thank you, sir. I would like to request. Yes. Thank you so much. I would like to request Dr. Bodhadev Mukherjee to kindly stay back. I would like to request Dr. BP Pandey to kindly felicitate Dr. Mukherjee.